and they're beginning to need more hospitals than the hospitals that we have. And we are looking at ensuring that then we implement those. And if there's a need to go beyond those, we'll be able to do that. So should there be a need for us to utilize to put up field hospitals in all the districts, we are ready and willing to do that as soon as the numbers that we have are giving us that direction. However, what we don't want to do, and we are not going to do, is put up facilities that are not going to be utilized. That is why we put up facilities in phases, so that we also look at the bed utilization of the facilities that we have put up. We are quite worried by the fact that we don't seem to see a lot of our people coming into the hospitals. Sometimes people wait 2 to 3 days before they come to hospitals, and by the time they come and get assessed, they have complicated. So we are calling on the people of KwaZulu-Natal to come to our facilities. We have specialists. You will be taken care of, and we have revamped our facilities, and we have the capacity to actually take care of our people, despite the fact that we have had a bad rep in the past few months. We have corrected that. From time to time, there'll be areas where there are issues that are coming up, and sometimes those become our blind spots, and we appreciate that the media from time to time will actually highlight those, and once those have been highlighted, we are able to zoom in and deal with the issue, whether it's an issue of management or it's an issue of infrastructure that requires the province to be able to fix. So we are ready and willing to fix where it's necessary for us to do so, but we do call on the people of KwaZulu-Natal to utilize the facilities that we have already put up, because the reason that we have put up this space was so that our people are able to get the treatment and the care that they need. I think with those welcoming words, I would like to then hand over to the Minister. Minister, and appreciate the fact that you are here with us for the next 2 days. We have been feeling very cold when you have been in all the other provinces. We really appreciate that our turn has also come. Thank you very much, Kabazan.
Thank you very much, MEC, members of the media, and senior leadership in the department, and fellow South Africans. We just want to give a quick sense of our visit into KwaZulu-Natal. As the MEC is indicating that I haven't been KwaZulu-Natal for quite a while, but in fact, this was the first province I came to when we spotted the first patient. And we spent the whole weekend at that time, and it sounds like many years ago when that happened. But we have actually, as the department, as well as South Africans as a society, have moved a long way from that point. We're now living with the reality of COVID-19. As we said before, COVID-19 is no longer a story that we read about from China, from Italy, from America. It is a reality where now each one of us can talk about friends, relatives, colleagues who have suffered the infection. And so it makes it very, very different from the time when we started talking about COVID-19 at the beginning of March. Now, what we have also seen is that through our models and the reality on the ground, we were expecting that the numbers were going to increase. And so we expected a surge to come at some point during the winter months. And when we put up the lockdown, we did say that would never stop the infection from rising, and we will also anticipate that there are many people who will be infected, and that literally anyone can in fact can be infected. That is now a reality that we are living in, and so what we have seen in the past few months has been a very different presentation of the COVID-19 pandemic from what we initially thought was going to be. Initially, we thought that this was going to be a huge surge in the whole country, starting with Gauteng being the highest, and KZN and Western Cape and so on. And of course, it has completely changed. Firstly, the surge didn't come quite as early as June, May, June, when we initially thought it would have come. And all our modelers indicate that the fact that we had an early lockdown deferred the the surge to about June, July, August. And so in that process, we have actually seen that for all the provinces, there were about 2 to 3 months when there was quietness, not much movement in terms of the spread of the infection. Although the numbers were growing, they were growing very slowly, and except for the Western Cape, which broke off immediately and started growing within the first few weeks of the lockdown, and the numbers went so high up. And we were very concerned about this, but we have also then been visiting the different provinces. Western Cape, I spent quite a lot of time visiting, and Eastern Cape, and of course now Gauteng and all the others, particularly Free State and Mpumalanga, when we're picking up some early signs of the infection getting out of hand. Now, yesterday I presented a pattern, which is what is now seemingly the reality of how this infection is going. The pattern is indicating that the trends of an early surge in the Western Cape and peak and then plateau have actually now been confirmed as a reality. We for a while didn't want to talk too much about it because there was no explanation from our side as to why the pandemic would behave like that. We've asked all the clinicians, the scientists, the researchers, and no one could actually explain. But we did confirm that at that point, the numbers of patients who were coming in did not match what was anticipated by the hospitals, as well as although the numbers of fatalities was high in Western Cape, it did not reach what we thought was, what we feared was going to happen. In particular, if you saw the challenges that took place in Spain, in Italy, in America, and so on. Now, this to us meant that there might just be slightly different presentation of the pandemic in the country. So for almost 2 months now, the Western Cape has shown not only a plateau, but also is showing decreased numbers in terms of people who are presenting in hospitals and the numbers of tests that people are finding positive. And we always, focus on it because we had lots of challenges with tracing and tracking, quarantine. It didn't happen too well, but nevertheless, we've seen the pattern of the infection. Now, about a few weeks later, excuse me, the Eastern Cape and Gauteng started lifting off, and the Eastern Cape now has actually plateaued at a slightly higher level than what the Eastern Cape had done. And it's now about 3 weeks that it's been slowly on a downward trend, and we are now observing what is happening there. And I think all of us have seen that in the past few days we've been seeing low numbers of tests being done. But the point is that the trends have been generally a downward trend, although we look at the tests with the changing criteria that we used. We are focusing on the most high-risk areas who are vulnerable, those who are under investigation, and those who present themselves in the hospitals. And so we have nevertheless seen that there's a slight decline. In fact, some of the major field hospitals, whether it's City ICC in Cape Town, whether it's the VW in Port Elizabeth, or in some of the large field hospitals that were set up, that have not really filled up. So I think the first thing that we've noticed is that we didn't breach our hospital bed capacity. Every time we had a press conference, I would be asked by the media, sometimes 2 or 3, 4 times in one press briefing, is South Africa ready? And we said, yes, we are. And then they said, but there are these problems. And we said, those problems do exist. However they exist, they will need to be solved. But at the same time, we are focusing on how to deal with people when the infection arises. And so we have been able to make that kind of impact. I think the lockdown helped us to defer the peak for a while, and therefore we're able to deal with the issues of the numbers of beds. Then we looked at the Gauteng. Gauteng took off with a a very high rate of increase, and up to giving us between 5,000 and 6,000 positive cases in a day. And we actually were very worried, and we spoke to a number of the clinicians on the ground. The hospitals were feeling the pressure, and there were some members, some reports, in fact, that said people can't get admitted in hospitals, they're being turned away, and so on. However, we looked into that aspect, and we found that, in fact, the admission wards, the admission centers on the outpatient basis is where the challenges were. And what happens here is that we had made given a directive that all hospitals must now create triage centers where you separate the patients up. If you are not sure, put those patients aside. If you are sure that they are negative, then you put them on to the negative side. If you are sure they are positive, you put them on the positive side. And that created a bit of a bottleneck. We had to then run quickly into Gauteng to open up that space. And then, of course, there was the issue of the tests, which was delaying and making it difficult for someone who's under investigation to be tested and the results to return quickly. We cleared the backlogs, and the last we discussed with most of the clinicians, the situation is that there's quite a lot of, the hospitals are quite busy in Gauteng. However, we're not at a point where there are problems of no beds available. In fact, the Nasrec field hospitals, on the second week when I went to visit, of available 500 beds or so, we actually had not filled more than 150. And it remains available at this point. What I think has assisted, and all the clinicians on the ground have attested to this, is the fact that there's been a suspension on alcohol, and this has reduced the trauma, motor vehicle accident, interpersonal trauma, the assaults, the gunshot wounds, the knife wounds and stab wounds, and pangas and all of that has been reduced. Now that makes a huge difference, because then it means, firstly, when people come in, you actually can attend to the very sick ones who now are as a result of COVID-19. And in this case, Gauteng has actually been coping pretty well with a lot of challenges, but is still coping pretty well. We have now seen in the past 3 weeks the trends from the testing in numbers in Gauteng is on a downward trend. And so the one province that remained with numbers that were high, that were increasing, is KwaZulu-Natal. And it seems, therefore, for us that the surge in KwaZulu-Natal came about 2 weeks after Gauteng, and 2 weeks after the Eastern Cape, and probably just about 6 or so weeks, was 6 or 7 weeks behind the Western Cape. So we must therefore focus on KwaZulu-Natal. And in KwaZulu-Natal, the numbers are such that now KwaZulu-Natal is the third highest in terms of numbers, whereas at the beginning it was the second. Right later on, it became the third, the fourth largest numbers. Right now, it's the third largest numbers. In fact, my expectation is that sometime during the course of next week, KwaZulu-Natal will have more positive patients than what we recorded in the Western Cape. Western Cape is in a downward trend. KwaZulu-Natal is an upward trend. And the numbers in the KwaZulu-Natal right now have been ranging around the 3,000, 3,005 and thereabout, and in such a way that in some of the days, in fact, KwaZulu-Natal had more positive cases per day, per 24-hour, than Gauteng. Now, this is the matter that has been of concern to us, that the province needs to be ready, and so we came here to assess that readiness. And certainly, we have said this time we'll just always make sure that we look at the big cities and look at the small hospitals. So this morning, I have been around. I got a briefing. I am firstly satisfied that the records of what numbers of patients and how the recording of the epidemic in all its different algorithms is actually being done properly. We met with the epidemiologists. They gave us a whole report, which I'm quite happy with. And secondly, we have seen that the numbers of patients are increasing who are positive, as well as the fatalities are increasing. But what is important for us is that there is no hospital that is already full to an extent that we no longer have beds in the nearby hospital. One thing that has been helpful both in the Western Cape and Gauteng is to create what we call the Bed Administration Bureau, which means that for every either district, excuse me, for a district, there must be a central location where there would be a recording of the available beds. This helps now when someone picks up a patient who's sick and the ambulance services pick someone who's sick, they phone this number and then they actually get the patient directed to that hospital rather than being taken to an area where they might be under pressure. This is what we learned as well, both in the Cape Town and Johannesburg, and the problem was that, if one ambulance goes to one hospital and then they're told, look, we're full, and then we go to the next one, even if they've now got a bed later on, the message that goes out would be that the hospitals were full. So this is working well now, and I'm very pleased to see that that's working. In fact, I've now been told that the number is made available even to the patient so that someone can actually call, and then they can decide whether the bed is available in such a place, and they move the patient where the patient will be assisted within the Durban-eThekwini region. Now that for me is a very good indicator of the fact that patients aren't going to fall off the cracks as a result of whatever problems might arise at any level. We've also seen that the occupancy, the bed occupancy, is still fairly low, and therefore that means that the surge, as it comes along, we will be able to accommodate as many of the patients that might be coming up as possible. So I went around, therefore, to have a look at Edenale Hospital. I was very impressed also with the way that they've organized their triage system, which is actually working fairly well. And I've also then seen that they actually fielded very senior professional nurses onto the front, and senior specialists to be the ones who are at the reception area. So they make a very accurate assessment of the patient and move them to the right places. We have also heard that there were challenges in some of the hospitals, such as Northdale Hospital, where the accommodation for patients was unacceptable. I'm pleased that there's been action taken in this regard, because we must actually make the point to the management that we want them to hold them personally responsible and accountable for any treatment that is below the expected. And so both in terms of the management of the protective gear for the health workers, as well as the care that the patients are receiving, we will therefore put a spot on investigation and then ensure that there's action taken at that level. In this case, the issue of Northdale has been reported to me, and we are aware that this matter was circulating in the social media. Actually, even before it was out in the print media, we had spotted it and we had already directed that the MEC must investigate the matter. And so we've got the report that there has been action taken in this regard. I think it must be a message to all the management that we would like them to take their responsibilities quite seriously, because there will be action taken on those who are not managing properly and those who are not ensuring that the quality of care to the patients is maintained, and those who are not ensuring that the protection to the health workers is not properly managed. And this is important because we say that our health workers are the soldiers. Now, a soldier goes into the battle, must be fully armed and fully kitted with protective gear, and they must be fully trained in terms of understanding the tactics of fighting, in this case, how to avoid the infection, so that they can save many more lives rather than they themselves having to fight for their own lives. So we have got the report now from Northdale Hospital, and then I then had a visit at the Richmond Hospital. Now this is a small rural town, and this hospital was a highly neglected hospital, which was mainly a TB hospital. And over a period, it really got dilapidated and was not being used, not even useful to the local community. And so I was also pleased to see how much work has been done. refurbished, good, looking as good as new, and with oxygen points put in place, and the best of infection control procedures are accommodated in that hospital. So clearly now the Richmond community has now got a district hospital, because when COVID-19 recedes, that hospital must now be opened up as a district hospital. I've come now to the Clarewood Hospital. Now, I used to work here. One of the most dreary looking hospitals, neglected hospital, was Clarewood Hospital. It does look good as new now. It looks well refurbished, and I've also been impressed to look at it and to see that it's really got a refreshing appearance. And all of that is for me very, very important, because we now are able to use that hospital to just get about 190 beds, which I think it would be useful for the nearby hospital to push their patients and refer them into this area. On the other side, we've actually been able to see one of the field hospitals rolled out within a very short space of time of about 5 weeks, and that it was even because there was a bit of a protest that delayed it for another week. So it could have been completed within 4 weeks as such. To about 228 beds, which is a very good number. So it certainly converts the Clarewood into about 400 beds for the southern part of Durban, Tegwini. It's a very useful contribution. In particular, it will be serving the Wentworth and the Nkosi Albert Luthuli area. So you've now got a very strong program of movement of patients from field hospitals for very mild symptoms, and then to more focused treatment in the wards, as well as the possibility of putting up a high care, which I think is very good. But anyone that complicates, have got all the big hospitals nearby, and the cooperation between the department and the university, the tertiary hospitals and the professors. We met them on the ground, and some of you would have seen the professor head of Department of Medicine. That is one of the things that's really making this thing to be a very collaborative process. So this is on the south of Tegwini. In the north, we went the last time on our visit with President to see Pixliga Isagaseme Hospital, which has got 800 beds. We haven't actually started using it. It's ready to be used, and therefore we are then saying that even if there would be a surge at any one time that increases from what rate we're seeing now, we've got possibly another 4 to 5 weeks even to roll out a new hospital anywhere where we might think we need it. And so I think that the province is pretty much on course in terms of readiness. We will be visiting some of the rural municipalities, the area of Madlangeni tomorrow. I worked here, as I said before. They focused on some of the neglected hospitals, and the idea for me is how some of those neglected, dilapidated hospitals get revamped, so that when we talk about instituting NHI, there are new additional hospitals that are now useful, that could have been a challenge in the past. So we are going to be working together to ensure that the issues of staffing are taken care of. We're also going to be making sure that the issues of PPEs for the staff is also taken care of, and that we tighten up management. Management needs to really manage, and they must work together with the trade unions and ensure that all the issues and the challenges that are being raised by staff and members of the unions are attended to, so that as we move on, the issues of occupational health and safety of our staff is taken as priority. The staff has got to be looked after. We have to make sure that our health workers don't continue to be infected, and certainly if they are, they shouldn't be infected from within the hospital setting. We do know that so many of us can also be affected at the community level, but we need to make sure that the infection does not really cross from patient to staff, and from staff to patient, and from colleague to colleague. So that's what we want to emphasize upon. Having said all this, we are not ready to give the figures right now. Quite a lot of compiling happens behind the scenes, and therefore it will not be complete at this point. And so there are some which are ready, some which are not. So we'll release the statement a bit later. But I think what becomes important at this point is just to indicate that we have taken seriously the analysis in terms of the trends, and we think that what we are seeing in terms of the downward, promising downward decline. I say promising, excuse me. I say promising because we always want to wait for a few weeks and confirm that the trend doesn't turn around. But we want to thank all the South Africans who have heeded the request and the directives to focus on containment. Those who have worn the masks and washed their hands frequently, used sanitizers, cough etiquette, as well as distancing, have actually given us the trends that we're seeing. They have made us have the infection, kind of sloping downwards in the way we're seeing. The fact that even in the Western Cape and Eastern Cape we're not getting towards zero is because there are still many more who are not wearing masks. The fact that we're not getting to a point where we say we've got no new infection is because there are still many more people who are not washing hands, not using sanitizers, and not distancing. So this is the message that we want to send to our people. Please, please, please let us use masks when we get out of our homes. Let us make sure we wash our hands. Let us make sure that we sanitize our hands. There are challenges that we can see because after about 3 weeks, we'll have a better sense of where the trends are in the country. Now, if this situation continues and more people use masks and distancing, then we might find a situation where there would be much, much lower levels of infections. So there's been a question that's been raised about why are we seeing rate of infection decreasing? Well, there will always be variations for various reasons. Variations where, like 2 days ago, they test to about 19, 20,000 tests. Then after that, it's about 34,000, it's about 40,000, and so on. Those on their own don't compromise our calculations. However, we have checked on a number of areas to say what is the reason why there are fewer tests. In some of the instances, they've said to us that they are not having enough patients under investigation who are coming with the symptoms that would have warranted them to be tested in the way they were tested before. There are also instances where they've been indicating that as they were going around testing, there are fewer people that needed to be hospitalized and therefore needing to be tested. But somebody asked me a question, why are we seeing more testing in the private sector than in the public sector? Well, in the private sector, whilst the people are following and using the protocols, there's also still quite a number of people who are who request to test. You have seen that people would go to some chemists, some of them, and get themselves tested. But also in the private sector, the testing went up to a point where the people who were going to be getting operations, they would actually even be tested, even though it's not a protocol requirement through WHO, but they've been doing quite a lot of that. So those are some of the variations, but it does not, as we analyze, yet distort the situation. In any case, as we move along, we keep adjusting our protocol for testing. We've actually asked the Ministerial Advisory Committee to look at, with the numbers, the way they are doing, and if you're running short of numbers in the way that some of the areas are doing, we might still want to keep the level of testing high, and therefore it will give us a proportionality that must show a decrease if the numbers are fine, but we shouldn't be having a concern that there are too few tests that we are doing. And so we are asking the Ministerial Advisory Committee to have a look at that and see whether, in fact, we would vary the criteria just to be able to make sure we cover in the areas where the numbers of patients are declining, so that we can keep a high level of testing. So we want to focus on that. The other issue that I think has become important for us has been the fact that on an anecdotal basis, as we have actually had a number of instances where people will get a a kind of flu-like illness, and within 2-3 days, then they pass. And we want to send a message to our communities that people must go to hospital. We would like people, don't stay at home and say this flu is going to get better. Get the hospital to test you, treat you, and decide whether you get to treat yourself at home or whether you stay in the hospital. And if you are admitted in the hospital, don't rush to leave hospital. Wait until the doctors decide you need to go back home. And this is all important because when we were analyzing in the past few weeks, there's been a debate about what is called excess deaths. Now, excess deaths are deaths that when you analyze daily deaths over in every week and compare with 2 or 3 years ago, you will find that there are numbers that are a bit higher. In this case, in South Africa, this was done, which was done 2 weeks ago. And when the figures were released, there was a lot of excitement that maybe we are undercounting the deaths, we are not reporting or under-reporting deaths. Well, actually, we're reporting as much as possible. There are 2 areas which I think are blind spots for many people in different countries. One of those is the issue of people who would have died before they are diagnosed. And those people, when they die before they are diagnosed, may have died of COVID, may not have died from COVID, and no one can ever know. And so if we looked at different countries, we found that the numbers were high in many countries where during this time they were finding a number of people who had passed. And therefore, we look at this concept of excess death in that way. We are therefore going to be encouraging that our departments must talk to the funeral parlors. People who died home, we need to make sure that we can swab them, just get a quick sense of whether they could have had symptoms suggestive of COVID, so we can swab them, because the excess death contains 2 groups of people. There would be those who would have died because of COVID, but no one diagnosed them, so no one knows it was COVID for sure, but we do know that they are there, so by the proportionality, nobody can tell. On the other hand, there are those who would have died of natural diseases, things that they would have been suffering from before, but in the process, they are not able to go to the hospital, either because they feel that they are safer at home, and then, of course, the disease complicates, or they fear to get to hospitals, or they might feel that maybe the hospital is full, and so on. There was a time when we had actually decanted our hospitals and encouraged everyone to go home and treated as many people out at home. We are saying we would like people to actually come to hospitals for basic services. Immunization is very important, that the children must be immunized. Well, baby clinics, so that we monitor their growth, their weights. It's very, very important. Contraceptives for family planning, very, very important, so that people can manage their lives properly. And chronic diseases, diabetes, blood pressures, heart diseases, cancers, and so on. We wouldn't really like someone's life to be compromised by some disease that was under control. And then all of a sudden, because they can't go to the hospital, their treatment is therefore, undermined or disturbed. And so we want to encourage people to come to hospital as much as is possible. We have a space because we actually have reduced trauma, and therefore we believe that we must focus on the real issues, not on avoidable problems, causes of ill health. And so our plea then to our people are that we deal with that. Then, of course, we just want to say that all the steps that have been taken by the President and that have been announced by the Minister of Finance in fighting corruption, we endorse, we support, and therefore, because we believe that COVID-19 is a crisis that we must not ever take advantage of and allow anyone to try to profit out of a crisis of this nature. And therefore, we want to make sure that we work together with Treasury to streamline the procurement processes, to make sure that there's no price gouging, that the prices are stable so people don't exploit government, and that the procedures are all properly followed, and that the quality of the PPEs are also assured, so that no one walks into a place thinking that they are fully protected, only to discover that the PPE is substandard. We will work together to make sure we close all of those loops. We will not accept any corruption. We will want to make sure that corruption is stamped out, not only for COVID-19. We are moving forward towards national health insurance. We don't want ever anything to be suggested that the NHI would actually be affected by any form of corruption, and therefore we support all the steps that have been taken by the President and Cabinet and the Minister of Finance on the issues of fighting corruption. Engifisa ukudlula kubona kancane nje iloko ukuthi siyafisa ukukhuthaza kakhulu umphakathi wakithi ukuthi wazi ukuthi lo mkhuhlane uyingxaki, kodwa umkhuhlane okhona ngempela. Uyingxaki ngendlela yokuthi uma uzizwa ngathi unomkhuhlanyana ungawuthathi nje ukuthi umkhuhlane ojwayelekile. Sondela masishane kodokotela emaklinikhi nasezibhedlela uthola ukwelashwa. Sikubona lokho kubalulekile ngoba kulamalanga kunabantu abaningi esizwa ke kade kunamakhosi abekhuluma ethi imingcwabo omningi manje abantu bashonela emakhaya. Mawubuza ubephethwe yini, hayi ubevela elihamba isibhedlela ube namaphilisi abewadla ube nezifo besimphethe. Kodwa mawusuthi uyalalelisisa uke wangenwa umkhuhlanyana. Manje siwuthatha sengathi umkhuhlane omncane kanti kuzoba umkhuhlane ozohlupha mase kukhona le COVID. Ngakho ke siyacela wonke umphakathi, kakhulukazi kulabo sebekhulile nalabo abanezifo abazilashelwayo, mabaqinisekise ukuthi mabezwa kungathi kungena umkhuhlane basheshe bayobheka odokotela bathole usizo. Insuku embili entathu lomkhuhlane uba namandla okungangokuthi wenza umuntu angasakwazi ukuvuka embhedeni. Manje sithi ke bayakwazi ukunqoba odokotela noma usheshe wafika. Abaningi uma befika bafika isifuba sesivalekile, uma nje uzwa ngathi isifuba sakho sesiyacinana sekusho ukuthi ulinde kakhulu ekhaya. Kufanele uye kungakafiki konke lokho ngoba odokotela banokwazi ukuhlola igazi babone ukuthi oxygen egazini iyancipha yini, ungakezwa wena umehluko egazini, iqambe kuzwakala isifuba sesicinana soke sekuhambe kakhulu. Ngakho ke siyacela ukuthi kakhulukazi abadala umuntu angathi hayi umkhuhlanyana nje wami ngizohlikihla ngeVicks ngizophuza iBostol kuzolunga. Sukuma nje uye kothola usizo kodokotela ngoba ungakwazi ukuthi lo mkhuhlane unakwe udlule. Ezibhedlela eziningi manje kunabantu abebelashwa benale COVID-19, abanye bawo 85, abanye bawo 90 years. Umuntu alashwe aphume abe ngcono. Kungathathi kubelula ukuthi hayi uvela ubesekhulile. Cha, awungahambi ngeCovid. Nanko nje umyalezo osubekayo. Sithi ke sicela ukuthi umphakathi wonke ukusukumele lokho, kakhulukazi abantu abadala. Into ehluphayo manje siyasifuna ukugcizelela ukuthi abantu abadala mabazaba ukuhlala ekhaya bazivalele. So abaningi bazihlalela emakhaya. Inkinga kunalabo abasha. Bavakashela abangani babo babuye bazobingelela ugogo, abanye bayabuya bavela kude endaweni ezikude la beqhamuka khona bafike bazobona abantu abadala. Asisho ukuthi ningabathandi, kodwa sithi sizigadeni ngoba mawumusha alizwakali kahle igciwane. Uyaphila nalo uhambe. Abaningi abantu abanaleli igciwane leCovid, iCovid-19 abanankinga bayaphilela nje bayimqemane, kodwa akusho ukuthi mawumqemane awuzoludlulisela komunye umuntu mawunalo. Ngakho ke siqinisekisa ukuthi uma umuntu omdala noma onezifo ezithile ekhaya engaphilile enomkhuhlanyana, kwabanye baye bakhala ngokuthi umphimbo mhlambe ubuhlungwana noma bayakhwehlela kancane noma bakhohlela kakhulu. Yabona umuntu masuthi uyakhuluma naye angawuqedi umusho ongakhehlelile, kuyahlupha lokho. Kusho ukuthi kufanele sikubheke bese kuba ukuthi umzimba mawuzwa ukuthi umzimba ubuhlungu amajoint wonke, enye into noma ukhathele uphelelwa amandla kusavukeki, uzwa ukuthi umkhuhlane noma umzimba uyashisa kakhulu, noma uyazi uyajuluka kubuye kubande. Zonke lezo zinto zigadeni umuntu asukume aye esibhedlela aye kodokotela. Siyakuhlola sibone ukuthi leli gciwane likhona, uma likhona sokulalisa makufanele. Masithi hambe uyohlala ekhaya ulashelwe ekhaya nalokho kusafanele. Kodwa nje sithi ke kubaluleke kakhulu lokho. Kodwa okugcina ukuthi umuntu onale nomkhuhlane lo ningabeke selimenza esengathi sekuyisici, kuyakhonjwa, useyabandlululwa, sekukhulunywa kabi. Lesifo songena nanoma ubani. ungamkhomba omunye umuntu kanti vele nawe usunaso. So into ebalulekile la ukuthi asisekelane, makuthiwa abanye abahambe bohlolwa bahlola. Uma sithi abantu abazivalele emakhaya bangaphuma abazivalele bangaphumi, ungathi ngizohlalelana ngoba ngiyaphila, ngoba abaningi bayaphila kodwa igcona balidlulisa kwabanye abantu. Ilonto ke sibona ukuthi ibalulekile ke emphakathini. Sithi ke kakhulukazi lapha KwaZulu-Natal sifisa ukuthi uma kukhona umuntu oshonela emakhaya, celani lapho ke kubangcwabi ukuthi sicela bamenze bamcheck ukuthi igcona le COVID like laba khona yini. Sizokwenza ke lokho kube into ezokwenzeka zonke indawo ngoba siyafuna ukubala sibone lapho ukuthi abantu banegciwane, ngoba usukuzwe manje kuxoxa ukuthi kube kunosibani banwana nomkhuhlanyana washona kodwa umhlobo wakhe kade bevakashelana naye ulandelile emva kwalokho. Ubani obenade enomkhuhlanyana naye kuyalandela kulokho. Akudingeki ukuze sifike lapho. Kubalulekile ukwazi ukuthi singakwazi usinqoba lesifo, ngakho sicela ukuthi umphakathi ususukumele. Abantu abasha nazo ukuthi abantu abadala uma ngabe ethi hayi ngizobuye ngivuke mncengeni ahamba ayohlolwa ngempela, ngoba abantu abadala bayaqinisela futhi abathanda ukubona izingane zixakeka ngabo kuba ngathi bayahlupha uma ngabe umuntu ethi nginomkhuhlane uhlale uthi uyagula. Cha, kufanele nikusukumele ngoba izodlula lesifo kodwa asingadluli sesilimaze imphefumulo eminingi. Ngakho ke lapha KwaZulu-Natal ke sikhona kodwa ubukhona baso sithi masibheka sibona ukuthi kuzothi kuncipha kwamanye ama-province kube kusaqhubeka ukwenyuka lapha KwaZulu-Natal. Izibhedlela zikagcwali yani khona, yebo sithe ake ume utshwala kodwa sikwenza lokho ngoba uma ukuthi abantu bayaphuza kuba khona izingozi eziningi, kuyalinyazwana, kuyadutshulwana, kuyagwazwana. And labo bantu labafika bopha ezibhedlela uma umuntu ephuma igazi awusakhumbula nanemask ukuthi akayifakile ufuna ukuphuthuma yena. Konke lokho siqoqe ngoba sithi sifuna ukuvula isikhala sokuthi sobhekana nje nale COVID kwamanje asibambisane. Masithi ke inamba sibona ngathi zifuna ukwehla kwamanye ama-province zehliswa ukuthi bakhona abantu abasebenzisa lama mask, abageza izandla, bafaka ama-sanitizer, baqaqane bangumiwe endaweni la kumiwe khona. Ngakho ke sithi basiza labo kodwa uma ngabe sibheka ayizufike ekugcineni lapho kuzothiwa iphele inya ngoba kusekhona abaningi ukuthi makuthiwa kunemingcwabo kuthi makuthiwa kunabantu abawu-50 abafuneka emingcwabeni uthola ukuthi nabantu abafuna ukushaya ama300 nama400 bazincoma abanye ukuthi hayi mina sithina seqile ku-50. Akuvumelekile lokho, kuyingozi. Funa sazi ukuthi kuyingozi ikona sathi akumiswe nje. Abanye basafuna ukuqhubeka namaphathi baphuze konke lokho kuyinkinga kufanele ukugada. Abanye abakunaki ukuthi uma sithi geza izandla kufanele bakusukumele lokho bakunaki. Zonke lezi zinto lezi ziyasiza. Ngakho uma sifuna ukubona leligciwane lincipha lifika phansi kufanele sikwenze konke lokho. Kodwa uma ngabe singakwenzi ingozi isekhona ukuthi lizobuya. Sesilibonile kwenzeka eSpain, sesilibonile kwenzeka eMelika. La bangathi liyehla liza kahle. Thela ngakafiki phansi laphenduka lakhwebuka labheka phezulu. Lenyuka kakhulu ke kunakuqala ngoba manje baningi kakhulu abantu asebenalo legciwane kana abantu abazinakile. So ke nathi sesaba lokho ke ngokwenamba ezikhona kuthiwa uSeptember sumgadi. Masizibheka inamba sibona ngathi ziyehla. Kusho ukuthi masithi usigadi uSeptember kusho ukuthi uma kuthiwa kuzovulwa kuyo ko level 2 ko level 1 seqala ukuba khona kufanele manje baye kosebenza endaweni ebezivaliwe, sekuvulwa amabhanoyi, sekuvulwe indawo eziningi. Konke lokho kuzohlupha. Abanye bayakhala ukuthi inkonzo kade uzavalwa kubuyelwe enkonzweni. Konke izinto lezi sasizazi thina ukuthi zinengozi engakanani, ingakho sathi akume ku50 yonke into. Kodwa manje sesiqala ukuphuma manje kulo 50 ilazo liqala silibuyisa khona. So masibona ngathi kuyehla sikubona sengathi kuphinde emuva kakhulu kusho khona la sinaka esidedeleke khona. So ilokho esifisa ukucela. So the last point for us is that whilst we're anticipating that there might be a declining trend, it's really a function of the containment measures, those who use masks and sanitations, hand washing and distancing and so on. But there's a risk that we can still have an upsurge. That upsurge can be worse than what we have seen already. We've seen those trends in the US, we've seen those trends in other parts in Europe. Everywhere where there's been a loosening of the containment measures, we see that the viral infection starts spiking and going up. So we are going to be starting to look at how to recommend to the Coronavirus Command Council what steps need to be taken now that we're seeing these trends. But what we need to really be very careful about is that we can't suddenly say that everyone must open up. There must be big meetings, there must be big rallies, there must be big weddings and big funerals and so on. That's a very risky area that we must really say. We will really plead that there must be an understanding as we deal with this matter. At this point, therefore, I would like to thank you for your time and your attention and for having interest in making sure that we follow the fight against the coronavirus. And so thanks to the members of the media and thanks to the members of the public and thanks to the MEC and all the members of the department for the work that you do. Let me thank all the health workers, those nurses, those doctors, those health workers all over. You are our heroes, and all the work you do we appreciate, and thank you for saving our nation. Thank you very much.
Thank you, colleagues. We'll take just 2 rounds of questions, and please may we limit the questions to 2 per person due to time constraints. When you do ask your questions, just direct it clearly. If you're asking the Minister or the MEC, please introduce yourself, your name, your surname, as well as the media house you're representing. Tuva, I see your hand over there. Kabil, number 2, 3, Karinda, 4, SABC, and 5 here.
Thank you so much, Minister. You talking about the trends that we're seeing in other provinces, that it looks like numbers are decreasing, whereas the province of KwaZulu-Natal, we're still projecting the same. Have you been able to understand why the surge in KZN seems to be a bit delayed when compared to other provinces?
It's Kabil from News 24. Either for the Minister or the MEC, just in terms of the situation at Northdale Hospital, how long was that sort of facility or that makeshift facility in place for? And I know that you mentioned in the statement yesterday that the CEO was off sick and now she's being redeployed back to her old position. Based on that period of time that it was there for, I know she was off for 2 weeks. Was she there for that period of time when this was being instituted? And have you had any other complaints about that facility for the period of time that it was there for? Thank you.
Good day, good evening, Minister Karinda from Newsroom Africa. Just 2 questions here. The first is, you spoke about the World Health Organization experts, the 17 doctors supposed to arrive yesterday. Have they touched down and in the period of quarantine? And the second is, you spoke about corruption and the concerns you've raised, and as Treasury is investigating various officials about corruption, can you also confirm that either you or any of your relatives have not received any allocations for tenders related to COVID-19 as well?
Thanks, Lisa. You're covered. Thank you. Orange?
Minister, Orange Singh from the Sunday Times. You spoke about patterns, I think, during the presentation that you presented yesterday. What sort of tangible evidence have we learned from, or lessons have we learned from the Western Cape, Eastern Cape, and Gauteng? And how do we look at maybe applying those lessons in our fight against the virus that's obviously surging here in KZN, or is expected to surge? And then a final one from my side, Minister, just clarity on about KZN. You said that by next week, you expect by next week this time KwaZulu-Natal will have more infections in KZN than what would be in the Western Cape. Is that to say that we'll have more in KZN next week than what will be in the Western Cape at the same time next week, or what was the Western Cape at its peak? Just wanted clarity on that.
All right. Thank you very much, colleagues. I'll take the Northdale question covered. Of course, let me start by saying we decided when we went there with the head of department that we are going to institute an investigation, and we are expecting a report on Friday that is going to come from the team that we have put in place. And we decided not to investigate it ourselves or get a team from within the facility. We've extended it to our partners, including the UKZN, because we've got very good working relations with the tertiary institutions that we have in the province. So we are utilizing that skill that we have there, and that report is going to come to us by Friday. But at face value, from our engagement with the management at the facility when we went there and the staff, that facility had been up for a couple of months now. And we would expect it to have been up for a couple of months, because almost 3 months ago, through the minister, through all of us, instructed all of us to ensure that we have what is called flu clinics in all the institutions. Now, how these flu clinics actually operate is that at the beginning, right when a patient enter into a facility, there is no patient that will go to either a ward or a clinic that they need to go to, or even if they had an actual appointment, without having gone through screening, therefore a flu clinic if it's necessary. So every facility is expected to have a smaller corner that where they are screening patients. That's a process that takes between 5 to 10 minutes. And that process, as a result of screening, is can have a tent if you don't have a proper structure. Now we are talking about a proper tent that is closed off. You can get in, respond to the questions that you have been asked, your temperature is taken, you go in. If you, right at the beginning of that process, you are seen not to have any of the symptoms, you are then allowed to go into the facility and go wherever that you needed to go to. But when it seems that you do have some symptoms, you then have to be redirected into a flu clinic. Now, flu clinics have to be inside the facility, because sometimes you might need oxygen, sometimes you might need a doctor to see you, you know, and all of that. So we found that in those days they actually decided to put everything in one space, but you know the team is investigating, and we will get that report. So at face value, it looked like this has been happening for a couple of months, and that is why in our disciplinary processes and in our engagement, the acting CEO is not immune, because she has only been off work for a couple of weeks now. But when all of this started, she was leading the management at the facility. So when we said we are taking actions, we then taking actions towards the management that took that decision to place a facility like that. The minister earlier on indicated that one of our main responsibilities as a province is to ensure that the dignity of our patients is actually sustained, and that is what we are working towards. And we, besides looking at what the management at facility level did not do, we are also looking at what the district level management had done. What did they do when they saw this? Because those are the people who are supposed to be on a daily basis managing the facilities that we have. We also have managers at a provincial level that are supposed to be overseeing the districts and the facilities. So, you know, the consequences to this might even get to a level of a provincial level, but we are still waiting for that report, so that we don't act as, you know, we woke up in the morning and decided we don't like this person, this one must be suspended. We must be procedural in our actions. Thank you very much, Minister.
Well, thank you very much. Let me start with the question. No, we don't have any tenders. I'm not aware of anyone on the family who's got any government tender for PPEs. I'm not aware. I've never heard of it. So the other questions, if I can just deal with them. The first question was about, one question was about why is KZN delaying the trend. Mainly what happened was when we did the lockdown was supposed to delay the spread of the infection. And so KZN did a very strong quarantine and isolation program. Contact tracing, they were very strong on that. And so same was Gauteng. So that actually discouraged the first few patients from spreading the infection, and they were able to contain the cluster infection. There was one area where there was a huge cluster, which was a hospital called St. Augustine's Hospital, and a few other hospitals. They were able to contain that. So if you were to look at the numbers of people that were involved at that point, it actually have created a huge explosion in numbers were it not contained. So both Gauteng and KZN were anticipated to be the ones that are going to give us the highest numbers, mainly because of the population size. Population size and the density of settlements. And so for the past, for about 6 weeks, they were able to stay, well, I think from the lockdown up until about 6 weeks ago, they were able to contain those numbers. It was only when we started to move to level 3, when there was a lot of movement and mixing of people, that all the provinces started showing the numbers that were going up. That's really what caused the delay. And so KwaZulu-Natal, by sheer numbers, was actually delaying after Gauteng. As you will see, the other provinces also delayed. That is because of the population movement, the population numbers, and the movement patterns of the community. So it's not surprising. That's what should have been. The exception was Western Cape. Western Cape shouldn't have actually bolted earlier, but it showed us something else that we had not been aware of, and that is the clusters can actually, because the clusters were in the essential services. So it's not like they did something wrong. What happened is that the clusters were in the food manufacturing, in food processing plants, in medicine manufacturing. It was also in shops, retail shops, all of which were allowed to be open at the time. And so that's really how things went wrong. So in the process, therefore, what we are seeing in the pattern is not surprising. What was surprising is when the Western Cape got into the surge and peaked earlier. So we have a lot of lessons that we have learned out of it. Amongst those lessons is the fact that the retail shops and a number of areas where people ordinarily have to be mixing are actually a high risk that we must keep in mind, and therefore it's going to continue. And we have learned out of that, and that's why when we moved over and where people were going into the mines, we had to actually say screen them before they start work. And the pre-screening and so on, which has been a well practice, we actually started encouraging it from that point. So those were some of the things. But one other lesson that we have learned is that don't say you know how it's going to happen, how it's going to behave. It's going to be anything. And so from that point of view, therefore, every one area will have slight differences. And because of those slight differences, we therefore need to manage it every day. It's a dynamic management where you find new things and then go ahead and manage. And we've also learned that you can anticipate a surge. It may not come to the same extent. You can also anticipate a surge, have hospital beds prepared, and then they may not actually fill them. So all those are some of the things that we've observed already from the Western Cape. And that we are then saying we will have to stagger. And then at a particular point, we might need to wait with new beds and give about 4 or 5 weeks period during which we know that if we're going to reach that level, we would have actually increased the beds to that kind of need that there is already. The other question, well, the WHO groups, the one group was supposed to land yesterday. Those landed, and then what we expect is that there will be a number of people who are landing on a continuous basis, and that the processes thereof will be over a number of days. So we will have them coming, on different days. I saw somebody in one show was asking, yeah,